Bad signal. Oh, hi everyone. We are at Mallard Creek Surgery Center and we are running a little behind today, but we should be starting around 10:15 if you want to come back and view the actual surgery. But beforehand, we are going to meet the team who will be performing the surgery today. So if you guys could introduce yourselves and tell us a little bit about what we're going to see today, that'd be awesome.
Okay. Hey, I'm Dr. Morgan. I'm one of the sports medicine doctors at OrthoCarolina in Concord.
My name's Scot Rheinecker. I'm Dr. Morgan's physician assistant at OrthoCarolina Concord.
So what we have today, we have a partial rotator cuff tear in a patient that's 63 years old. A partial rotator cuff, meaning the rotator cuff is frayed. It's not completely torn in two. He is symptomatic. He's having pain in the upper aspect of the arm. He has weakness when he tries to move the arm away from his body. He's failed a conservative treatment program, including a cortisone injection and physical therapy. And today we're going to be using a Regeniten bioinductive patch to try to stimulate the body's own natural healing response.
So this is just an example of kind of a mock-up of what the actual implant looks like. So the actual implant is about the size of a postage stamp, and there's two different sizes that we have. Typically we'll use the larger size to give us more of a coverage over the rotator cuff. So this model is looking at the tendon as if we were looking from the lateral side of the shoulder looking inward. So the area of tear would be right at the footprint of the rotator cuff, so the patch will be laid upon this area right here. So this is an example of one that's already been fixed into the tissue. So just to look at what the actual implant looks like, it comes furled up in this little plastic sheath, and then what we do is we just go in through a small incision on the lateral side of the shoulder and then just unfurl it.
Okay.
And lay it down on the tendon, and then we're actually going to tack it in place to hold it provisionally, and then once we're happy with the provisional fixation, we'll release the tines, slide this out, and that just leaves the patch intact. So the way we provisionally tack it, we use these bioabsorbable staples that insert into, basically they kind of come in and just insert from the wheel that comes with it. And then just basically just tack these in place at different intervals throughout the tendon to kind of hold it in place. And then on the footprint of where the tendon attaches, we'll use these other type of staples that are going to go right into the bone. And these are absorbable staples also through this device. We'll basically put this into a small incision and then tack these in. And this just basically makes a little hole in the bone to kind of give you a line where the actual anchor will go into the bone. We'll just tack that in place.
Awesome. Well, we'll see you guys in a little bit once we are in the OR. It should be very, very soon, so stay tuned to our Facebook page and we'll talk to you shortly. Hi everyone, so we are back at Mallard Creek Surgery Center, a surgery facility affiliated with OrthoCarolina that offers outpatient procedures and orthopedic surgical services for patients of all ages. So today we are going to be showing you a new technology that we use on patients who have pain and weakness with a partial rotator cuff tear. And with us today, who we met briefly earlier, are Dr. Bobby Morgan, who is a sports medicine physician at OrthoCarolina Concord, and Scot Rheinecker, physician assistant, also from OrthoCarolina Concord. Dr. Morgan, there's an analogy that you use a lot with your patients to explain a partial rotator cuff tear because it's different from a full-on tear that has to do with a frayed rope. Can you share that with us?
Yeah, so the rotator cuff has thickness to it. And so if you think of the rotator cuff as the rope isn't torn completely in two, but it's frayed. And this is the patient's undersurface of the rotator cuff, and you can start to see the fraying where it's starting to become detached from the edge of the top of the arm bone through that. It's not completely torn, but it's starting to fray. And this is what a partial rotator cuff tear looks like. This is his bicep tendon where he has some tearing, where his bicep tendon attaches to the socket. His attachment is loose, and that's what we call a slap lesion or superior labral tear. Here's the socket on top of the shoulder blade bone, and then this is his humeral head or the ball that sits on top of the arm. So we're going to go in and use the Regeniten bioinductive patch to fix his partial rotator cuff tendon tear. But first we're going to clean up his bicep and clean up the shoulder joint along with doing a removal of a bone spur.
So Dr. Morgan, can you tell us a little bit more about what the implant is intended for?
the main indication of the patch is to fix partial rotator cuff tears, and it stimulates the body's own natural healing response to allow for new tendon growth and to prevent further tendon degeneration.
Y'all seeing this at home, how cool this is? And what we're observing right now is a scope of the shoulder. So a small incision is made and a tiny camera is inserted into the shoulder through a needle, which allows our team to see the injury, and the sheath has a camera on it. And they work to make repairs by watching the screen here. So the screen right above where the surgery is actually happening.
So now we're going to move to above the rotator cuff in the subacromial space. So there's the top of the rotator cuff right there. The wispy stuff that you see in through the side, that's all bursa. So when you say you have bursitis, that's the inflammation of this tissue right through here. Straight stack. So the first thing we're going to do is clear out the bursitis. So we have this little instrument that will act like a little home rotor-rooter and clear out the tissue.
When you talk about rotator cuff tears, if you think about rotator cuff being basically like the ceiling, if you have an articular-sided rotator cuff tear, that'd be like having, kind of a hole in the ceiling. If you have an interstitial tear, meaning some tearing within the tendon itself, that'd be like having a hole in the insulation, kind of between things. If you have a bursal-sided tear, which is the side we're on right now, that'd be like having some shingles missing from the roof. So a full-thickness tear means it goes all the way through. The continuum of tears you can see articular-sided, which is kind of what he had, which is on the articular side facing the joint, or you can see bursal-sided or full-thickness. So the patch is indicated for the partial-thickness tears, which is what we see in him right now.
And we know that the patient is currently under anesthesia. Can you give us a general idea of how that works?
Typically what we do with shoulder surgeries, we'll do general anesthesia just for comfort of the patient in most cases. You will do typically a nerve block with the patient. And that does two things. Number one, it kind of blunts the body's pain response, to the surgery. So it kind of controls the normal mediators that we get in response to pain. So it helps to kind of blunt that response. In addition, it allows them to have to administer less anesthesia for the patients. And it makes them more comfortable when the patient wakes up, because they wake up, they don't have a painful arm. And that anesthesia, that pain relief lasts anywhere from 12 to 14 hours after the surgery. So it kind of helps their body ease into the process when they're recovering, when they're waking up as well. There's a number of different ways that you can do that as far as the anesthesia. A lot of it's just surgeon preference and anesthesia preference. This is just one way that we typically will do it.
Now we're just cleaning the undersurface of the tissue from the undersurface of the shoulder blade. And once we get this shown, we'll show you the bone spur that the patient has that causes compression and irritation and fraying of the rotator cuff.
One of our followers on Facebook just asked if there's anything new that could assist with repeat tearing of rotator cuff.
So that's one of the big things of this bioinductive patch. It's bringing new tissue in. So before this was available, we would tell patients we can't give you a new rotator cuff. We could just repair rotator cuff that's already torn.
Okay.
So we use the analogy, it's like having a hole in your jeans. Before the patch, all we could do is stretch the tissue to sew the hole up end to end. But now this would be like using a patch on your jeans to bring new material in. And by that, we ought to get a healthier rotator cuff, a thicker rotator cuff that ought to give us more power when using the arm and less chance of re-tearing. All right, so we've cleared off the bone. This is the undersurface of the shoulder blade here. This is the rotator cuff. So when you raise your arm up, the rotator cuff rubs on the bone spur, and that's how it'll start to get frayed. So what we're going to do is use a little Dremel and shave off the bone spur to give this some room so it will not start impinging on the rotator cuff.
So just kind of pan around. We're looking from the back of the shoulder to the front of the shoulder, just for perspective. That instrument's coming in from the side of the shoulder.
Okay.
To the outside of the shoulder. The acromioplasty kind of serves two purposes. Number one, it helps to kind of open up the room, the space that the rotator cuff has to move underneath. And it also allows us more working room inside there to do what we need to do around the rotator cuff as well.
And how long do these patches last?
So the patch will stay for about 6 months, and what it does is it incorporates kind of into the native rotator cuff and absorbs in. So by 6 months, it'll resorb in, and the new tendon will grow into it. So it's not something that we have to go back in and remove or replace.
Okay.
So just one surgery. So you can see we started to flatten out the edge of the shoulder blade bone, and we're just working across from outside to inside, and we'll come across and remove this other aspect. Virgin.
This is how we got everything set up here on the back table. So basically, our graft's ready to go. We just basically insert that through a small lateral port along the shoulder, and just like we showed earlier, just click it, it unfurls it like a parachute. Place that on the tendon. We'll provisionally staple it in place, and then once we have adequate fixation, we feel we can pull it out. We'll release it and pull this out, and then finish the fixation once it's in the shoulder. And then these are just the bioabsorbable staples that we'll use at different intervals to tack that in place to hold it to the native tendon of the shoulder. And then these are the anchors that go into the bone to serve a more secure fixation to hold it in place. Basically at the footprint where the tendon inserts on the bone. Kind of overlap that area.
So one of our followers just asked if one of their repairs tears, can they use this for their next procedure?
So yeah, sometimes rotator cuffs are common to re-tear or re-fray. So you can use this if you've already had a rotator cuff tear, and if a repair re-tears and it's a partial tear, you can place the patch on and use it.
Okay, so just for partial.
Yeah, or if it completely re-tears, sometimes we'll re-sew down a complete tear back down to the bone and then place this patch on top to help prevent it from tearing again.
Great.
So now we've seen the bone spur that was removed, and if you look just towards the inside, there's the end of the collarbone. And he's had some symptoms up on the top aspect of his shoulder from his collarbone arthritis, and we're going in there and clear out the arthritis.
So we're looking from lateral side to medial side right now. That's just from an orientation standpoint. So the front of the shoulder is to the right, back of the shoulder is to the left. And that's the end of the collarbone right there that is kind of the overhang. That's the end of the collarbone.
Okay, great. And what's the recovery time after a surgery procedure like this?
So it's actually much quicker than traditional rotator cuff rehab. We'll have them in a sling for usually up to 2 weeks. We'll let them start some gentle active assisted motion, usually in a week or so after the surgery. It's about half the time of traditional rotator cuff surgery, which is usually up to 6 months to a year of recovery for traditional rotator cuff repair. In most cases, folks are back doing lifting, exercise, 12 weeks or so, after this type of surgery. The pain relief is usually pretty significant afterwards. Folks hurt much less after this surgery than they do after a traditional rotator cuff repair. You're not really pulling any tension on the tendon, which is one of the things that may hurt more with traditional rotator cuff repairs. You're basically stretching that tendon, which basically activates the stretch receptors of the muscle and the myotendinous junction, which causes discomfort inside the shoulder. And that's why most folks that have had a rotator cuff surgery done, or know folks that have had rotator cuff surgery done, they have a lot of times have some different stories about it. It was a long rehab, difficult recovery. With this, patients come in and typically are taking very minimal analgesics after the surgery, and they're usually quite comfortable. But the rehab is a little bit more aggressive, and we'll start letting them use the arm within reason, within parameters. We have a protocol that was developed at OrthoCarolina that is specific for this type of surgery and for this type of implant. For the first week, generally we're just waiting for wounds to heal. We let them shower within reason, bathe within reason, just keeping the portals covered just so that they don't stay saturated or anything like that. So it's basically local wound care, ice of the shoulder, gentle range of motion, getting them out of the sling, kind of as quick as we can, basically to maintain their motion so that folks don't develop any stiffness in their shoulder. You want to continue to kind of rehab the rotator cuff to basically activate those muscles so that all the muscles fire in the correct pattern that they need to. Most of what rotator cuff rehab is getting the muscles to all work synergistically together, because all the muscles have to work in a certain firing pattern to make the rotator cuff and make the shoulder work efficiently. And in many cases, folks are a little weak kind of coming into it because they've had pain, they've had a little bit of dysfunction, so they're not using the shoulder like they normally would. So we're kind of working on a little bit of, taking up, trying to fix that problem, but in addition to letting things heal also. Still have some discomfort just from the bony work that we do a lot of times. And that can leave folks with some soreness after the surgery, which is not out of the ordinary.
So this has been super interesting, especially as our viewers, they've been leaving comments. We have many people still tuning in, but we're gonna take a quick break while you guys wrap this up, and we'll come back to show our viewers the rest of the surgery. And we also wanna mention that if you visit OrthoCarolina.com, you'll find more information on rotator cuff injuries and this implant if you view our blog and use the search feature. We'll see you guys soon.
This is the top part of the rotator cuff that's frayed. We're looking from the outside of the shoulder back towards the socket would be right through there. And now we're going to take the Regeniden patch, there it's in, and then we just deploy it. Now, like so. We just lay it just like putting a rug down.
Scott,
Corner down from this one. Yep. So there might be a couple more times or anchors. Good. Keep it coming there.
And can you explain again what we're watching now for our viewers who may just be tuning in?
So this is the bovine Regeniden bioinductive patch, and it's healthy bovine or cow collagen. And we're laying it on top of the rotator cuff in a partial thickness tear to stimulate the body's natural healing response. And over the next 6 months, this will absorb into the patient's rotator cuff tendon, again, supporting new tendon growth and preventing disease progression.
And we understand that the patch is actually anchored to hold it to the bone. Is that correct?
Yes, they're absorbable the purple staples are absorbable. Yes. Coming. And the blue is just an outline, so we can tell. Start coming across. Yes, we can tell the outline of the patch. Grab the corner of the front side. So we just place these absorbable staples at different intervals to attack the patch in place to the native tendon. And then we bring one across.
And one of our viewers wants to know, can this type of patch be used to patch other types of tears, such as a labral tear?
It is not indicated for labral tears at this point. Hopefully with more design and more research, that'll be a next step for it. If that makes it come up there. Hold it down. So now we're going to put a this is an anchor that's going to go into the bone. Good. Another bone anchor.
So one thing our viewers might not know is that this implant is made from healthy cow collagen, which makes the tendon repair thicker with more power and strength. So there's a lesser chance of it repairing. Purple anchors. Now we're just going to fill out putting some of the purple anchors in. Almost ready to end it, loading in a second. So we just had a few viewers tune in. Do you mind telling us at what point in the surgery we're at?
We're at the point now where we're just kind of getting the last little bit of the patch in and stapled down. So these are the purple or absorbable staples. The patch is the blue outline. Up. Get one in the middle. Right there. And let's get one out on the edge and then we'll come back to the bone a bit later. That bone there. Okay. Come back in. This is our last staple going in.
Would this patch be a valid option to reinforce posterior stabilization repairs?
At this point, it's not. It's just indicated for rotator cuff repairs and not for capsular or labral type repairs. But now you can see the patch is adhered to the bursal side or the top part of the rotator cuff. And over the next 6 months, this will incorporate into the patient's native rotator cuff, giving a healthier, better quality rotator cuff. And that's it. Fairly simple.
Awesome. Well, thank you guys, Dr. Morgan and Scot Rheinecker, for being with us today. And thanks for all of our followers for joining us today live inside the OR at Mallard Creek Surgery Center. And if you'd like to learn more about rotator cuff repair, Dr. Bobby Morgan, Scot Rheinecker, or this particular type of surgery, please visit OrthoCarolina.com. Have you just started?
Okay.
Hi everyone, we're at OrthoCarolina Concord today, and we are here with Dr. Morgan and PA Scot Rheinecker, who performed the partial rotator cuff surgery that we live streamed last week. Thank you all for watching, and thank you both for being here today. They are here to answer some of your FAQs that you asked during the live surgery. So let's get started. So someone asked, how do I know if I am a good candidate for a patch repair?
So I think the first off is to make sure you're having symptoms that match the diagnosis. The patch is indicated for partial rotator cuff tear, so where part of the rotator cuff is frayed. The usual symptoms are pain, weakness when you move your shoulder, and the pain is usually localized out to the outside of the arm. And if you match those symptoms and the diagnosis is confirmed, usually with an MRI, that you have a partial rotator cuff tear and it's given you problems and you failed conservative treatment, usually consisting of a period of time of rest, physical therapy, and possibly a cortisone injection, then the patch is usually a possibility at the time of surgery.
Okay, and a few of our patients had asked, or they noticed that the patient in the video was sitting in a upright position for the procedure. Is there a reason for that?
Well, a lot of that really just depends on surgeon preference. There are two ways you can do the surgery. You can do it in what's called the beach chair position, which is the position that we use,
Okay.
Or also the lateral position. A lot of it's just based on the surgeon's training, comfort level, what assistance they have in the operating room. With the popularity of commercially available arm holders now, it becomes really just a matter of personal preference. You know, before with the beach chair position, you had to have someone actually holding the arm, and now with most of the commercial arm holders, you can have the arm position in space and have the assistant basically helping to work the camera, insert the anchors. So a lot of it just comes down to personal preference and surgeon preference on the positioning.
Great. And would this patch be a valid option to reinforce posterior stabilization repairs?
Right now, it's not indicated for stabilization procedures or procedures where we're going to work on the capsule or the lining of the shoulder joint. It's just indicated for rotator cuff, partial thickness rotator cuff repairs.
Okay. And the next question was, how does this patch compare to using human donor tissue?
It's a good question. We do use human donor dermis or skin that's allograft. That's usually more for augmenting a full thickness rotator cuff repair or using it to bridge a gap when you can't repair the rotator cuff. Human donor skin or dermis is not usually used for partial rotator cuff repairs because you have to use sutures to anchor it down. And that's where the Regeniden bovine allograft patch really benefits because it's meant for partial rotator cuff repairs. It doesn't require any suturing. You saw the purple absorbable staples where you just staple it and it will integrate into the native rotator cuff.
Awesome. And our next question is someone's specific experience. They said, I had regular rotator cuff repair done twice in the last 2 years, and it's torn worse than before the first surgery. With this surgery, with the rotator patch be a good option to ensure a better outcome?
Possibly. Scott and I do use it for full thickness recurrent rotator cuff repairs where we're doing a repeat rotator cuff surgery or revision surgery. As long as you can get the rotator cuff muscle stretched back out and pulled back down to the bone, we will repair the rotator cuff again and then place the Regenodin rotation patch on top of it to improve the biology and the healing chances. And our goal is to allow the tendon to heal and to heal thicker. And by using this Regenodin bovine patch, where hopefully we'll get a thicker tendon so we'll get more power to the arm and also decrease the recurrent tear rate.
And speaking of multiple surgeries, do you still do scope with repeat surgeries?
Yeah, so that's a good question. Many folks think that if they've had a surgery done, that the only way to have it done is to have it done with the open approach. In many cases, we can actually see more easily and have better visualization by doing it arthroscopically. It's minimally invasive to the patient, so you're not taking down any muscle or tendon when you're doing the approach. Because once upon a time with the revision surgeries, that was a fairly significant complication. Would be if the muscle or tendon didn't heal. So then you've got a rotator cuff tendon that's torn and you've got the muscle on top that doesn't heal. So we just do this arthroscopically because the visualization is just as good in many cases and allows us to do a more minimally invasive surgery for the patient and still see what we need to be able to see.
Okay. And can you have an allergic reaction to the patch?
Since it's been processed, all the living cells are removed from the patch, so there's not any allergies that you have to worry about.
Fantastic. And how long do these patches last?
They usually will incorporate into your own rotator cuff over a 6-month period, and the purple saples you saw in there resorb to over the course of 6 months.
Awesome. And a few people had commented that the surgery seemed to go by very fast. Are these kind of surgeries always this short?
Usually, a lot of it's how often you've used the product,
okay,
how much shoulder surgery and the surgeon and team's experience. Scott and I have been doing this for a while. We've worked together on a daily basis for the last 7 years and been doing this surgery for about 2 years. So we have the routine down, but what you saw in the video was the speed of it. We didn't have to edit it to do any of the surgery. So it's about that quick.
Yeah, that did seem to go by quick. And the final question is, can you talk a little bit more in detail about the recovery process?
Well, the recovery is a little bit different than for a traditional rotator cuff repair. When folks have had a traditional rotator cuff repair, the arm is immobilized in a sling for a minimum of usually about 4 weeks. And during that time, they're very slow with the rehab. Usually someone else is moving the arm for them or a therapist is moving the arm for them. So we don't actually let them start any active motion where they're actually using the arm for usually anywhere from 4 to 6 weeks after the surgery. With this procedure, we let them move much more quickly. So usually they're in a sling for maybe 1 to 2 weeks. We get them out of the sling at that point. We let them start some early active motion. Usually we kind of keep some parameters in place so they're not stressing the rotator cuff too much to potentially impede the new repair, the patch that we've laid on there. But we'll let them start some active assistive, meaning they're using the muscles, but maybe having the other arm helping them or having a therapist help them a little bit, so they're kind of jump-starting their own active motion much more rapidly. So usually it can shave usually a few months off the rehab as far as the way that the folks are getting back into using the arm more efficiently.
That's fantastic, yeah. Well, those were our FAQs from our viewers, so thank you both for coming back and talking to us today and getting those answered.
Thank you.
If you guys have any more questions, please head to OrthoCarolina.com, and if you missed the live surgery or want to view it again, it's still on our Facebook page. Talk to you later.